Good afternoon. Good afternoon, everyone. Welcome to the Holiday IMPARTy in partnership with Dalhousie, New Brunswick. My name is Natalia Fana, and I will be the moderator of today's presentation. Before we begin, I want to offer a quick introduction to IMPART for those of you who may not be familiar with our research team. The IMPART investigator team is a national virtual research institute headquartered at Dalhousie Medicine, New Brunswick in St. John. Our team is composed of 45 academic and clinical partners across 8 universities and 6 provinces, as well 25 community and funding agencies, 15 private sector company representatives, and 2 provincial government departments. IMPART's mission is to think boldly and utilize our network to improve the outcomes of vulnerable patient population, starting always with innovation developed here in New Brunswick. We apply intersectional thinking between social and medical innovation and have brought together a diverse and inclusive team of experts to support activities from fundamental research to applied interventions with vulnerable populations. Earlier today, the Dalhousie Medicine New Brunswick graduate students started the IMPARTy with their graduate student lunch. Our agenda for the rest of the IMPARTy is the following. In this session, we'll hear from Dr. Daniel Dutton, also known as the King Dutton, on his research on policy and population health. Following his presentation, we'll have a Q&A period where you can ask him any burning questions you have about his research. At the end of this seminar, I encourage you all to join Dr. Dutton, Dr. Brunt, and myself for a virtual happy hour where we'll play some online games together and have a good time. So I would like to introduce you to Dr. Daniel Dutton. Is an assistant professor in the Community Health and Epidemiology at Dalhousie University. He is based at the Dalhousie Medicine New Brunswick campus in St. John. His current research is focused on social epidemiology and public policy, namely how can governments influence or mitigate the impact of social determinants of health like low income. Most of his work is quantitative, utilizing large data sets and modeling strategies from economics and epidemiology. His primary interests are population level exposures and their impact on poverty and health, how governments can address these exposures, and the distributional impacts of addressing those exposures. Currently, that work focuses on homeless, low income, and governmental policy. Dr. Dutton is also the scientific director of APTA, an age-well hub designed to bridge the gap between researchers and policymakers, with a focus on policy changes that improve the quality of life for older adults. He is also part of the IMPART Research Collaborative. He has taught or currently teaches econometrics, statistics, epidemiology, and population health classes. Prior to his PhD, Dr. Dutton worked for a short time in the Ontario Ministry of Finance. You can also find him on Twitter. Dr. Dutton is the proud owner of the Dutton Research Group mascot, Odin. Odin is a Saint Bernard whose hobbies include cuddling and sitting on people's lap, eating food extremely quickly, digging up the garden, great asset to have, and getting pats from anyone passing by the house who notices him. Odin slobbers on everything and everyone while trying to steal food, meaning he's banned from most research group meetings. Amazing. With this said, I will pass the floor to Dr. Dutton.
Thank you, Natalia. I didn't realize that you would be reading the extended version of my bio. So thank you very much.
My pleasure.
I am going to go into presentation mode here. If you could just confirm that you can see this where my mouse is moving around.
Yes.
Okay, perfect. Thank you very much for inviting me to do this. This has been a really fun thing to prepare for, and I I feel like I've made it maybe too self-indulgent. So I'm going to try and do my best. I see there's a Q&A button and a chat button and lots of buttons for me to push, but I'm going to avoid the temptation to push those buttons. Natalia, feel free to interrupt me if the chat and Q&A get out of control and I need to stop. Feel free to ask me a question at any time. And I will just go ahead and get started. I didn't know what to call this, so I called it my Christmas Spectacular. Levels of spectacularness will vary by attendee. So that is Odin right there. He is the research group mascot. I'm not sure how old he was there. He's not my best friend right now because he keeps waking up at 1 in the morning, making me take him outside. Thank you again for that introduction. I introduced myself again here, but you just heard all about me. The only thing I wanted to do was throw up the spelling of APTA, and if you Google APTA, you'll be taken to that web page. But I'm a professor at Dalhousie, and people ask you to do talks, and you say yes, and then they ask you for a title, and it's kind of a weird thing because you haven't thought about what the talk is going to be about, and so you give some sort of weird generic title, which I have now seen like 3 different versions of, and so I ended up mashing all of those titles together, and that's what I'm going to end up talking about. So there's going to be some population health, there's going to be some COVID-19, there's going to be some policy, and there's going to be some social terms of health. But I'd say the last title is probably closest to what I'm going to talk about, but it's also Christmas time. And so in the great tradition of Christmas talks, I've made it kind of a lighter version. So for example, the BMJ has this Christmas edition tradition, and they come out with stuff like parachute use to prevent death and major trauma when jumping from an airplane on RCT. And this one, they find that parachutes don't do anything. And it's kind of a ha 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 type of joke. I wouldn't say it's drop dead hilarious, but it's it's a kind of on the lighter side. And then I was talking to Keith Brunt, and he said, "Hey man, just talk about your career, because there's going to be lots of trainees there." I said, "Oh, okay. Well, I'll also talk about my career a little bit, but I'm under 5 years into my current position, so my career is not what you might consider a storied and great example." But then I thought, what would be compelling if I were a trainee watching a newish old guy assistant professor do a talk about their career? I'd like to know what their life was like when they were in my stage, and so I'm just going to talk about that a bit. But I'm also have a lot of training in economics, and economists on Christmas are these kind of like sad Price is Right trombone take on everything. So we're going to try and make it light, but also I can't fight my nature to be dour and depressing. So I've tried to liven it up as much as I can with pictures and stuff like that. But if you get too depressed, just post in the Q&A and say, "Be happier," or tell a joke or something. So here's the outline of the talk. And talk about my career such as it is, some general points. Maybe somebody in the trainee role will get something out of it. If you already have a job, congratulations. Maybe you'll learn nothing from my career, in which case you can sit back and feel accomplished. And then I will get to the academic part of the presentation. And I'm going to have to talk a bit quick because I got 45 minutes. But the great thing about recording is that I can talk as quick as I want, and people can just rewind it and look at what I just said. And so I wanted to start talking about my career, and I thought, well, I should start an undergrad for any of this to make sense. But that seems like a million years ago for the youngs who are currently in graduate school. So you got to believe me, things were more similar than they were different, and it's totally relatable. I am also young and hip. So before I get into this, I just want to say that most people who give you career advice recommend you do what they did. That was my experience. My mom, who has no university degrees, said to me something like, "You should do all your university degrees in a row because you might forget something." Professors who also did all their degrees in a row agreed with my mom, and people who didn't disagreed with my mom. And so this advice, such as it is based on the context of what I did. And so what I'm going to do here is tell you what I did. So I did what most people do, and I got an undergraduate degree, and then I transitioned to my master's degree immediately. So my undergrad was in economics, and I determined that if I want to do economics for a job, I'd have to do a master's in economics because all the government economics departments were hiring master's educated individuals. So that's what I did. I picked my university to go do my master's in by looking at all the places that sent me an acceptance letter and picking the one that gave me the most money in a city I'd never been to before. Highly unscientific. I doubt anybody would recommend you make decisions that way. but that's what I did. So I did my undergraduate at Queens. I grew up in Southern Ontario. I said, oh, Calgary, I've never been there. And so I went and did my master's degree in Calgary. That was literally my thought process. Then I got a job. I got a job at Queen's Park at the Ministry of Finance in Ontario. So, excuse me, that's the Ontario government's Ministry of Finance in Toronto. This is the building we worked in. It is about as exciting on the inside as it looks on the outside, but this is apparently a marvel of modern architecture built in the 1950s called the Frost Building. This was a great job in that it opened my eyes to what working in economics was like in the government. I wasn't doing a lot of economics. I was part of a brand new team forecasting health spending for the government of Ontario. And I'll never forget, we put all this effort into thinking about how to build a model. And one of my colleagues, his forecast was take last year's spending and add a constant. And he was right. He nailed it exactly how much health spending happened that year. And so, I discovered that government work was not for me. But when you transition from a master's degree where you're making like, I don't know, I can't remember how much I was making. Let's call it $20,000 a year. And then you're in your first job. And after a series of promotions, by the nature of the unit was expanding and we were all getting slotted into jobs. You're looking at 75 grand a year. It's really a different standard of living and quality of living. But being the individual that I am, I have this personality quirk where I didn't like doing this job anymore. And I got kind of bored. Lots of people are able to accept boring jobs for like 4 times the salary of what they were just making in their master's. And I think that's fine, but that's not what I did. So what I did after that was get bored and decide I should do something else. Now, I love this picture because this man convinced me to go do my PhD. This person's name is Dr. Herb Emery. He's an economist at the University of New Brunswick now, but at the time he was my master's paper supervisor type individual for my end of my master's program at Calgary. He said, come back and do a PhD. I said, I don't want to do a PhD in economics. He said, what about public health, where there's a lot of applied statistical work. And so I switched to a PhD in a completely different field. I love this picture because it makes him look like an evil supervillain, but he's a really nice guy. Been a great mentor for me my entire life. And then, before I finished my PhD, I did the thing they recommend you not do, which is I got a job. And then I got a postdoc after that. And during the postdoc, I had my son. His name's Jacob. Here's a picture of him playing with Pikachu. He's still a rather large Pikachu fan. And because he was born with a rare genetic condition, that first postdoc, which was at the University of Lethbridge, resulted in a lot of travel back and forth to the Calgary Children's Hospital. And so these turned into 7-hour round trips. We ended up moving back to Calgary, which is where I'd done my PhD. And then I did a second postdoc at the University of Calgary, which is not, again, what you would be recommended. What you'd probably be recommended, they'd probably say something like, if someone's giving you career advice on how to perform in academics, they might say, don't have a kid. That's advice you hear all the time. And they'd probably say, do something like do your postdoc at the largest institution that will accept you. Try not to do your postdoc at the same place you got your PhD. But that's what I did. And after that, this little chubster takes up all my time. I started applying for academic jobs. I finally got one. Okay. This is not a very romantic story. This is a story of lots of starts and stops and readjustments and changing career paths just when you start your PhD. And I would say that it's atypical. Most people in professor roles don't have paths that look like that. And so if you want to talk to me about that and how you're feeling and what you're doing, I think it's important to talk to as many people as you can. And so I'll be open to chatting. Things that I like is the work. And as I say, that's the reason I quit my job. The government paid a lot more money. I love the flexibility. And I love that my coworkers are people who I can relate to and are similar to me with respect to the things they value. That's really important. And that was not the case at the government, because government just got a job. It's no problem. Lots of people work at the government, but it wasn't for me. Things that I hate. There are a lot of administrative time sinks when you're a professor. You end up working a lot because of them. I'm talking like black hole tasks where you just discard your time at work. This results in evenings and weekends, and I'm not glorifying evenings and weekends work, but objectively at the end of the day, I have to produce things. And sometimes the only way I can get them done is by working evenings and weekends due to the aforementioned Jacob, Odin, and these administrative time sinks. It is not to be overlooked the difficulty of what happens to your social circle every time you move. It's very hard to maintain relationships, even friendships. And so that's a real thing. And I have less money than I otherwise would have had. And so Keith was like, yeah, give him some advice. I was like, man, I don't know if I've got advice. I didn't plan my career very far in advance until the start of my PhD. When I started my PhD, I said, I'm going to go become a professor one day. And it took a long time, well, 10 years, I don't know, a long time. But a lot of people aren't like me. A lot of people will start their undergraduate degree and say, I'm going to medical school. That is what I'm going to do. And they will continue to go down that path until they get to medical school and they succeed, and great for them. I'm saying there are non-standard pathways. I didn't win many of those things that I would call Person of the Week awards or scholarships or accolades that look good on your CV. And a lot of people who put value on those things could feel very depressed if they don't win those things and feel like they're objectively don't have many employment prospects. That is not true. I would say that I was, and probably still am, highly competitive for non-faculty jobs because of my main skill, which was technical applied statistical work. So I encourage you to look at the skills you are learning and try and acquire ones that I would call generalizable. So soft skills, how to talk to people, how to write emails. I mean, basic stuff like that. Anything that makes you a person who others like to work with due to either your productivity or your ability to compose yourself in a normal fashion are all strengths. I definitely think those are overlooked, particularly in academics, where we overvalue technical skills. But due to the aforementioned technical skills, I wasn't worried about my employment prospects. So when I'm giving you advice, keep in mind that I had other employment prospects. It's important to give people chances. To people who are not trainees here, I think it's really important. Please give people chances and give them chances to fail spectacularly with little consequence. So I gave so many presentations that were just objectively awful. I tried to make jokes and they bombed. And I went back to my office and I said, what was I thinking? I am an idiot. Having those experiences are really key because they help address like you tying up your ego in your work. I think it's really important for you to have some safe distance there. And finally, not to be overstated, I have an extremely supportive spouse. She is a physician and we got married, and PhD students are not great marriage prospects. Further, I make like $1 million less than my wife. And she was willing to move her work situation around to accommodate mine, which is not the case. And that I'm very thankful for that. And that's something that not everybody has. Okay, so this is not advice. I'm not telling you to get a supportive spouse. I'm saying that my advice is obviously colored by all of these experiences. So my interpretation of what's important is colored by these experiences. Now here's some real advice. I would say this is my most important one that I try and tell graduate students and trainees all the time. Unsolicited or not, I'm going to tell you, do not let temporary fluctuations in your mental health and well-being have a permanent impact on your career. Okay, lots of people feel depressed and feel down at different times of their career. The key is not to have a meltdown or do something that will permanently change the pathway based on you feeling how you feel at your lowest point. Mental health problems are not your fault, but they're your responsibility to take care of. And I think nobody will have a problem with you taking time to deal with them. And if they do, I'll write them an email so full of vitriol, they will change their opinion. Further, don't let opportunity pass you by because it doesn't resemble what you consider to be a textbook good career move. My postdoc at Calgary, for example, would be considered not a textbook good career move, but it worked for me at the time and gave me the opportunity to study a lot more homelessness data than I already had access to and get in with some homeless research in Canada. So there were upsides. I tried to make the most of this pivot. I think that people who do well make the most of these pivots. There are lots of people who are, for some reason or another, seen as stars through no real merit of their own. It's just about making opportunity out of situations and letting other people help you and being valuable to others, rather than strictly on your own individual merit. And we can discuss that more casually if you like, outside of this presentation. And get lots of people's opinions. That's the only other thing I'll say in terms of advice. These are all softball advice things. I didn't know what to say with respect to advice, and it's a Christmas presentation. So I wanted to just get this out there because I probably don't know you. In IMPART, I have very few people who I actually work with. And so I would probably never talk to their trainees. This is probably the first and only time you've seen me talk. So now that I've used a third of my time talking about myself, I'm going to use the rest of the time talking about population health, COVID-19 and policy. I see there's a question in the Q&A. I'm going to click on it. Why is Dr. so smart? Why is Dr. Dutton so smart? How do I book Odin for events? You can have Odin. If you want Odin, you can have him. I'll give him away to you for free as long as you commit to not murdering him, because some days I am at the end of my patience. Okay, thank you, Dr. Brunt, for that question. So when people think about COVID-19 and population health, they think of goofy research like this. Excuse me, I should say unorthodox research questions like this. So here's an ecological study on deaths per million in your population and how much cabbage you eat. And then this was tied in a paper that had like very important biological diagrams that I can't understand, where you have enzymes and arrows pointing at one another. And there's some reason that eating cabbage would prevent you from dying with COVID-19, but at the population level, it simply remains unconvincing. So people look at this kind of result and they're immediately skeptical that this type of research is valuable, because COVID-19 is an infectious disease and we need to learn more about vaccinations and hard scientific stuff. Population health, what I do, has very little to contribute. And I hope to change your mind by the end of this. When we talk about COVID-19 and policy, it's mostly reduced to these behavioral interventions. Please wash frequently and maintain social distance. You know, we've been hearing that since the beginning. Some people feel like there's nothing new under the sun with respect to that. Even the meme accounts are getting in on it. I love bird rights activists. I think it's very funny. And kicking that one bird, kicking that other bird, I find to be a hilarious image. So that's why I included it. But this is most people's interpretation of those three words together in the title. What I'm going to talk about is, there's the other title that I was using for a while. I'm going to talk about the lightweight version of that title, which is simply an assertion that population health is a public good. Okay. How are we doing for time here? I turned off my phone. Excellent. Oh, look, there's a timer here. Okay, we're doing well. So population health is a public good. In order for this sentence to make any sense, I'm going to define population health and public goods. Okay. Population health. There are many definitions of population health because there's many definitions of health. And you can be forgiven for not knowing that population health is actually kind of a piece of jargon. It's considered an approach to study of health where we care about the health of the entire population. And so the Public Health Agency of Canada has this definition in blue. Population health is an approach to health that aims to improve the health of the entire population. That's a lot of improvement, and to reduce health inequities among population groups. So I said there's many definitions of population health. They all have similar flavors in the sense that they all talk about improving the health of the entire population, right? And reducing health inequities. Okay, so you wouldn't necessarily know by looking at the word population health that health inequities is a particularly relevant part of that. And often population health research focuses on things that affect the entire population, which we will sometimes call social determinants of health, which also typically have some sort of gradient relationship with health. Classic examples: income, more income, better health, less income, worse health. But what's interesting is that the people in the highest income group typically have better health outcomes than the people in the second highest income group, despite the fact that people in the second highest income group would not be considered poor or poor off or materially deprived in any way. So that's population health. Okay, what's a public good? Well, obviously a public good is non-exclusive and non-rival. Am I right? Those are pieces of jargon. Non-exclusive means you can't limit access to this thing to those who pay for it. And non-rivalrous means a person who's using it doesn't stop another person from using it. So most goods like t-shirts or apples are exclusive and rivalrous. If I buy an apple, you can't have it. If I eat it, you can't also eat it. Public goods are things like street lights or national defense. These are things that we provide and we put up and we pay for. Everybody can enjoy them regardless of how much they contributed, and we can all enjoy them at the same time. It has nothing to do, there's some definitions of public goods that make them seem like inherently noble. Like there's nothing about the benefit of society. The benefit to society might be quite small. It might be actually quite beneficial for only a few select people, but they're still public in the sense that even if you don't use them, you still have the option value of using them. The problem is that they're often underproduced due to free riding, right? Think about people who highly value living in a clean environment, who go ahead and buy a Tesla that pollutes less. People like me who value the environment but don't buy Teslas are free riding on the effect of those people who bought Teslas. So similarly, public good, clean environment, people who care about the most make changes in their life to do so, and it's underproducing the value of a clean environment, despite the fact that I might actually value a clean environment. Unlike in a market where if people are willing to pay more or less for something, price adjusts, quantity adjusts, and we're left with a market equilibrium of something. So like with respect to most things, we have an amount that makes sense under market assumptions, but public goods not so much. And so if population health is a public good, that means that people are benefiting or being punished by a level of population health, that is to say the quality of the population health, not the discipline, that is driven by the average value and the distribution of outcomes. And I think COVID-19 really underlines this, because if our population health with respect to COVID-19 is poor, it doesn't matter how good your health is, you still can't go back to living a normal life. You're still having to accommodate the fact that people who are worst off are having a higher incidence and perhaps more serious consequences of COVID-19, which is affecting your ability to do what you want. Okay, so that's the underlying idea between this population health as a public good idea, and I'm going to try and outline it with a bunch of COVID-19 and policy examples that are work I've done along with many talented researchers during this pandemic. And now, first of all, I gotta say, I'm astounded I've done anything during this pandemic, because that little chubster Jacob, who I showed you earlier, he sure takes a lot of time, particularly when he's at home away from school, which has happened. And working from home was a difficult transition. So I'm going to acknowledge that COVID-19 has not been great for anybody. So I'm as astounded by you if this looks like a lot of research, because it really hasn't felt that way. And it's been a bit of a giant pain in the ass. So the one good thing about COVID-19 is nobody asked me what epidemiology is anymore. Everybody knows. Some new neighbors moved in across the street. We were talking, oh, what do you do? Oh, professor, what's your department, epidemiology? They knew exactly what I was talking about. And that has never happened before. So in order for this population health public good thing to hold, I think that some truths have to be expanded upon about COVID-19 and COVID-19's impact. The first is that cases and policy responses drive healthcare consumption, which I think most people agree with. I shouldn't have written cases. I should have just written the policy response, because that's what I end up talking about. I don't end up talking about cases. And same with the second one, cases and policy response drive behavior. Again, the data all comes from New Brunswick and Nova Scotia that I'm about to show you. And these are places where cases were unremarkable until very recently. So in the data I'm looking at, cases are practically irrelevant. And then I talk about the equity element. So the first data I'm going to show you comes from the St. John Regional Hospital. This was put together by Valancy Cole, who was a medical student here. This was a RIM project. And as the project grew sort of in sophistication and maybe data needs, lots and lots of people joined in on this project. But I'm just going to say it was Valancy's because she's the first author. My research associate and I were involved in the data processing. So what you're looking at here is visits to the St. John Regional Hospital Emergency Department, okay? And they ended up splitting them into three groups. There were emergency visits, standard visits, and low acuity visits. And that's sort of in their order of importance. Emergency visits, good thing you went to the emergency room because this is an emergency. Standard visits, maybe like a broken bone. So it's not exactly an emergency, but it's a standard thing that you get treated at the emergency department. And then low acuity visits, you've got the sniffles, you could probably go see a primary care physician. And so each of those gray lines that goes up and down are the cases per day. And you can see that there's some days with a lot and some days with not a lot of visits. And that's true pre and post COVID. But if you compare the blue and the red lines are the smooth estimates, the moving average of those choppy gray lines. And that green rectangle indicates time after which we instituted a state of emergency in New Brunswick and what happened to emergency room visits. And so you can see that the emergency visits, the most important visits, decreased by 24.3% during that green time versus the pre-time. And this is just called a difference in difference estimate. So we look at the difference between the red and the blue line, pre and post that green rectangle, and what you're left with is the difference conditional on the fact that sometimes visits go up and down, irrelevant of COVID status. Oh, excuse me, of what year it is, right? So you can see that blue line goes up and down across time. Doesn't really have anything to do with COVID. So the difference in difference accounts for that. The drop was larger for these standard visits that I described. And the drop was even proportionally larger for the low acuity visits. But you can see the patterns were about the same. I'd like to point out here that that's a pretty discrete change. It's almost like nothing was going on beforehand. Then there's a state of emergency declared. Then there's a huge drop in emergency department visits. There were COVID cases in New Brunswick before that state of emergency was declared, and people knew about COVID before that state of emergency was declared. That is a discrete change based on a policy change. Okay, and the same thing's true for Nova Scotia. So again, the same group, researcher in Nova Scotia, instead of taking one hospital's data, took all the Nova Scotia emergency department data they could get their hands on. I'm just going to call that all of Nova Scotia. I don't know if it's actually all of Nova Scotia. I'm going to argue the difference is probably negligible because there's one hospital that accounts for a lot of Nova Scotia's emergency department visits. And they show the same thing. So if you look here, you've got your emergency, your standard, your low acuity. Low acuity saw the biggest drop between your pre-post COVID stages in 2019 and 2020. That's Tara Dawn, forthcoming publication of some kind in the World Journal of Emergency Medicine. Again, same thing. And finally, for a longer period of time, we've got data from all of Horizon Health Network, which is New Brunswick's English-speaking, what's it called? Health service delivery network. The proper term for this is escaping me, but it's basically the arm's length organization that runs all the medical care for the Department of Health. And so you can see, this is called residuals right here. It's, oops, wrong screen, excuse me. Residuals. Residuals means that we accounted for stuff like, it happens to be December the 25th, and there are fewer visits to the emergency room on December 25th. So we accounted for special holidays, we accounted for date. And this is over a number of years. And then we look at what happens from 2016 to 2021. So this was up to December 2021. Oh, no. This is just to populate. You can see there's no data here. It's up to October 2021. And so we have high acuity visits and low acuity visits, and you can see that they bounce up and down. So high acuity visits go along a relatively normal rate, then they drop according to that state of emergency I talked about earlier. Then they come back up and then they drop again according to another policy change, almost up to normal. Yet another policy change, drop again. And you see that low acuity visits never really return, whereas high acuity visits do. And so Canadian governments have been trying to get low acuity visits in the emergency room down forever. And their strategy has been, hey guys, let's not go to the emergency room for small things. Don't forget to go to your primary care physician. But people did anyway, except for during COVID. So this shows that people can not go to the emergency room for low acuity changes, and we can control their behavior based on policy interventions. Recall, this is not driven by COVID cases at all. There's no COVID in New Brunswick, virtually no COVID during this time period. Okay, so policy changes can change emergency healthcare consumption, and it also changes behavior in a larger context. So that's what the next point is about. So this next slide is, I'm going to use alcohol sales to exemplify point 2 because it's something I have data on. But you can look at things like domestic violence, intimate partner violence, any kind of food insecurity or purchasing behavior. And you can see that there are policy responses to COVID-19, almost all driven by work from home orders, right? But with alcohol in particular, we closed, bars and stuff like that. And so bars and restaurants closed. This is, again, we're back to residuals. So we've taken out the effect of stuff like in the summertime, people buy more alcohol. So if I showed you the raw data, you would see it looks like a nice series of waves because in the summertime, people buy more, on the holidays, they buy more. So this has removed that pattern. You can see it's still a nicer little set of waves, but centered around the 0. And then we experienced in New Brunswick about a 25% increase extremely suddenly at the declaration of the state of emergency, and it remained high. This is public alcohol sales. These are sales by the liquor store, ANBL. But if I were to show you this for all alcohol sales, it would look extremely similar. That would include restaurants, bars, agents, etc. And so, nothing. There was no surprise that alcohol stores were to remain open. And you can see that this effect of the higher sales persists for some time into 2021. So nobody was, surprised that alcohol stores were remaining open. No one was worried about these alcohol stores closing, but people were still buying about 25% more alcohol. Okay, why is that, I wonder? Well, we ran a survey and that ended up in a couple publications. And so I've got the results here, and that's a lot of words on the screen. A terrible presentation technique would be to read these words off the screen, but I'm going to do it real quick. Just over 12% of respondents reported drinking more frequently after the start of COVID-19. Okay, so only 12% of people that we interviewed reported drinking more. There's about 1,000 people in New Brunswick, 1,000 people in Nova Scotia. But a high proportion of the people we interviewed reported increased psychological distress, meaning increased feelings of stress, loneliness, hopelessness, bad feelings. Of people who reported that, there was a much higher likelihood of 2-time relative risk ratio increase in drinking more. Okay, so policy changes is driving behavioral changes, which is in turn related to how you're personally coping with these feelings. Women were females were less likely to be stockpiling or purchasing excess alcohol, and older adults. So now this is a little bit of a epidemiological point. This odds ratio is 0.98 with a confidence interval from 0.97 to 0.99. I made it yellow because I don't think this is reportably different, but it is statistically significant. That's why it's in the paper. Papers are team efforts, aren't they? And so my opinion doesn't matter, but this got reported anyway. Those who reported drinking more frequently since the start of the pandemic, and those who reported an increase in feelings of stress at the start of the pandemic, increased odds of excess alcohol purchasing and stockpiling. Okay, now it's true that these people might have been feeling malaise about COVID-19, but I will point out again that COVID-19 existed before the policy change, which was correlated almost perfectly with the increase in alcohol purchasing. Now this line doesn't look very discrete because what it does is smooth the effect over this period of time. But if you look at the gray dots, which are virtually invisible here, you see it's quite a discrete change in alcohol purchasing behavior. How are we doing for time? Oh no, only 5 minutes left. Okay, let's motor. I'm arguing that there's an equity element. So this is New Brunswick. This is the work of Daniel Hanscombe, another medical student, and he has looked at visits to the emergency room for low acuity reasons by level of ethnic diversity deprivation, which is a weird thing to say, I agree, but it's one of the many measures of deprivation Statistics Canada proposes. And you can see that darker areas on this map, like St. John, Fredericton, Moncton, have higher proportions of low acuity visits for people with people from areas of high visible minority status, high amount of immigrants. So what does that mean? That means that the people who were avoiding the emergency room from those previous slides were people who could afford to, and they were almost all white. New Brunswick is like 3% non-white, and we saw a 6% increase in low acuity visits of people from these areas post-COVID. that means that they had no other option. Okay, so if we're relying on public policy changes where people avoid exposures or avoid whatever type of unnecessary trips outside of your house, there are some people who do not have an alternative. They have to simply go to the emergency room despite inherent risks that, you know, the hundreds of missing white low acuity emergency department visits could avoid. Okay, so that's the equity story, and that equity story is not New Brunswick specific. Other parts of Canada that have, you know, a higher proportion of visible minorities have reported the importance of race-based data on things like death rates. Again, so Christmas with economists talking about sad stuff, death rates and infection rates amongst people who are already systematically deprived. Here's some news about this paper. Basically, it shows that job loss has exacerbated food and housing insecurities for visible minorities, immigrants, and refugee communities. And these people were worried about family violence, mental health, and the prevention of COVID-19, which, like, everybody was worried about, but a lot of people were able to take steps to remediate or mitigate their worries, which some people were not able to due to already a lack of resources. So we're left in a situation where if population health is a public good, those who are the worst off in society are the ones whom are accumulating the worst health outcomes. They're getting COVID and potentially dying of COVID. And so the population health of a society suffers, meaning we have to disproportionately direct resources towards these groups. And what am I saying here? All I'm saying is relying on these behavioral changes to limit exposure. And most of our policy so far has been, hey, please do the right thing, which is easy for people to do if they're well equipped to do so. The groups that are deprived already are the ones who are bearing the disproportionate brunt of COVID-19 infections. And since we live in the same society as them, it behooves us to intervene. Now, at this point, someone's going to say something like, okay, so it's just behavioral. Why don't people behave better? Why don't just wear a mask, or let's get angry at anti-vaxxers? That's all very fun. I love your fire. I love your dedication to kicking ass. However, it's not so much that the people in these groups are worse behaved. It's that even with the same behavior, they could have worse outcomes. And I love putting up this image, which is about Kai Hai's alcohol hospitalizations entirely attributable to alcohol, which they observe to be twice as common amongst low-income individuals. But those low-income individuals aren't necessarily more likely to drink more. In fact, the high-income individuals are more likely to binge drink and drink more. So why are these low-income individuals being admitted to the hospital twice as much despite drinking less? Kai Hai proposes it's these things like higher stress, limited social supports, poor diet, physical activity. In other words, social determinants of health. In other words, the environment in which these people live their lives. So if drinking and hospitalization for drinking, which is very much like an individual level correlation, is patterned by the environment within which you live your life, if the dose response mechanism between drinking and going to the hospital for drinking is driven by social determinants, it stands to reason that COVID-19 outcomes are driven by the same mechanism. And so let's wrap it up. Policy changes that drive behavior in predictable ways, and policies reliant on behavioral change, and an environment you're in impacting your susceptibility and your ability to change, means we are going to have a situation where we have to, if we want to improve population health, that is this public good that lets us live our lives the way we'd like to, we have to disproportionately direct resources to people who would be losers under this policy. That what I mean is people who bear the brunt of these policy interventions that are essentially requiring you to do the right thing, stay home, control your risk of infection. We have to intervene on behalf of those for whom this is too much, for whom they would not be able to change their behaviors because they rely on public transit or they have no other primary health care, etc. Okay. And I will say that the purported or real difference between adherence and non-adherence or any other us versus them categorization is irrelevant once you embrace the idea that you're already paying for them having bad outcomes. If the health of the population was what matters for your ability to return to normal life, it truly doesn't matter what they think. What you want is policy that mitigates a poor hand of the social determinants of health. Okay. Before we end this, I just want to say that if anything you saw here was intriguing to you, and you would like to look at the idea of getting a master's degree in my department, and you happen to live in New Brunswick, or maybe you want to move to St. John, New Brunswick, for some reason, you can contact me via email, via Twitter. We can talk about St. Bernard's if you want. We can talk about technical applied statistical problems, data problems. I hope you enjoyed this little chat. Hope it was what you were looking for. I'll open it up to questions. Oh, I see 3 chat bubbles that I've neglected this entire time. Someone said authority. Ah, Keith said authority. Oh, I'm Talia.
Hi, you can go ahead and if you want to read out loud, or I can read whatever works best for you.
It looks like there's a Valancy shout out from Paul Atkinson. Keith Brun says authority, and I think that was when I was stumbling over my words of what to call horizon. And JF says, great talk, thank you, Dan, which I appreciate, thank you.
And for our attendees, if you would like to type a question in the Q&A box, or if it works in the chat box, whatever works best for you. We do have a question from Boon Kik. He's asking, would you like me to go ahead and read the question, Dr. Dutton?
Sure, yeah, I can see it here too, but why don't you read it for the recording?
Sounds good. While the state of emergency reduced ER visits by standard and non-acute patients, was there consideration of which other sectors would have to carry the patient load, example pharmacies? One question. 2, and or the health impact of patients not seeking healthcare help, and 3, how does this inform future policies?
Okay, so there are 2 elements to the emergency department visits story. So it's true. Nationally, there was an opinion piece in the Toronto Star or something saying that emergency doctors are very worried about that first group, emergency cases not showing up, because we have no reason to believe that people are having fewer strokes or heart attacks, but they're not showing up at the ED. And so this was cause for concern. Maybe Canadians are so scared of COVID and we need to like tell them, hey, if you'd be one of these serious cases, you should probably still show up. I imagine that the average individual experiencing some health outcome doesn't know their triage status. They don't know that they'd be like a worst off individual. You could have an aortic dissection and be like, oh, I feel kind of weird, and not know this is something that you need to go to the emergency room for. If you're worried about COVID, maybe you don't go. So there's definitely that healthcare help angle, the second part in here. But my interest is a little bit broader, and it's like saying, if we can see changes in emergency department visits when that correlate with policy changes, and we can imagine that those emergency visits are a proxy for behavior in general, because we don't have a good measure of how people are doing with respect to infection control behaviors like wearing masks, limiting their social group, etc. So emergency department visits, for all its imperfections, is kind of a proxy for that, because it does react to those policy changes. And so what I'm particularly interested in is looking at how long those changes take to degrade, and when we'd have to institute a new policy change to get that same effect, particularly contingent on the fact that we've already made that first policy change. So we know that the impacts of policy changes, once you've already done them, is not the same. So that's what I'm interested in. With respect to the first part of that question, was there consideration of other sectors that have to carry the patient load? I'm going to say no. I didn't think about pharmacies and stuff like that. I'm imagining that with the low acuity visits, we're seeing people not show up or go to their family doctor like they're supposed to. But again, I don't think people typically know that they're a low acuity person before they show up at the emerge. It's good. Good question. Standard and low acuity patients. Okay. Oh, 2 more questions from Dr. Brunt. So we are best to spend overtly than bear the costs covertly for vulnerable populations in terms of their health, and stop blaming them for access. Yeah, exactly. And stop blaming them for accessing resources or denying them resource access. Natalia, I totally jumped on that and read it before you got a chance to read it. I'm sorry. So this goes back to like how governments treat spending on people. Spending on the healthcare system, like politically, is always seen as a good thing for the health of Canadians. But we know that from my work and other people's research, there are other ways to spend money that has a bigger impact on population health, because you're addressing the health of those with the worst health outcomes. And it's not necessarily on the healthcare system. Once someone shows up to the healthcare system, things have gone wrong. So if you can prevent things from going wrong through enriching social spending or income support or these other programs that people rely on, perhaps their life expectancy will rise before they even show up at the healthcare system. And you've got a better shot of them living long. And yeah, the way that we treat spending on social services is very much like we think we're doing people a favor and it's a charity. But in reality, if we don't spend on them there, we're going to end up spending on them when they hit the healthcare system anyway. So redirection of funds from the healthcare system to social spending makes sense to me if your goal is to improve population health. Now, that being said, it's extremely simple for me to say these envelopes need to change funding, but what particular programs need to be intervened on? I would argue off the top of my head, shelter and income support, but how that's operationalized is very complicated, and I'm not going to pretend to know how to do that. But yeah, I think the whole stigma around people for using the emergency room when they're not supposed to, I think is not helpful. The ads are the way we approach that problem is sort of the way we've approached COVID. We've been like, hey, everybody, if you could just do the right thing, that'd be great. And I don't think that will definitely have equity impacts, because it relies on people's ability to do the right thing, right? Not regardless of their opinion on whether it's the right thing to do. Keith has also asked another question. Natalia, why don't you read Keith's second question?
Definitely. I will go ahead and read Dr. Atkinson's question.
Oh.
He posted it in chat, and then we'll move to his question, if that's okay with you.
Sorry, guys.
Dr. Atkinson is asking, excited to see all of this work going on here at DMNB. Dan, how can we engage grad students and MDs in population services research best? Example, are there 3 top questions your team and clinicians could work on together? Just like the population health research study?
How can we engage grad students and MDs? Okay. I think that one of the, okay, so these are 2 groups. I'm going to treat them separately. So let's start with physicians. Sometimes physicians have an ability to access data that is relevant to a question that makes sense when they conceptualize it. The people outside of medicine don't get, right? Like, it's hard for me to even imagine what those questions are because I'm not a physician. But sometimes we can think about how hip surgeries and wait times for hip surgeries and who presents needing for hip surgery pre and post pandemic informs us about something, because if an MD will have knowledge about the process that gets a person into that wait list, and they'll say something like, like this has to do with people aren't presenting the same way as they used to, or people's family members who used to pick up on this aren't picking up on this. I was talking, this is not an MD example, but I was talking to somebody at social development, and they said, we have a lower incidence of child abuse cases because normally those get picked up by the teachers at school. And when kids are learning at home, they're not getting picked up. So that's the kind of like inside baseball knowledge that is needed to unlock an important research question. And if a physician has these questions and doesn't really know how to operationalize the answer, that's where the research group, DMB or whatever, is valuable. And so at Dalmed, New Brunswick, we've started this group called, oh man, what a name, Health Services Research and Population Health Research Group. It's not a good acronym, it's just a bunch of consonants. But I'm the head of that group. I'm the chair, and we get together like 3 times a year and we talk about opportunities. And I think that joining groups like that, or at least plugging into groups like that, would be a place to get eyes on this kind of question. And so that's where I see the relationship being: a data provider, research question generator, and operationalizer. And hopefully there's some room for like mutual gain by working together. Graduate students. Graduate students are often seen as like this disposable labor, but I would say that the medical students that were working on things here really did pull a lot of weight. Particularly, I'm most familiar with Daniel Hanscom, who I showed the picture of the New Brunswick map that he put together. That guy took like data and a question out of nowhere and took it to a submission to like a real hard to get into journal. And that was an astounding amount of work. And it required like, you know, some frequent check-ins. And I think he really represented himself well on that work. He's a medical student. Graduate students, I think, have longer timelines, and typically they're locked into a research project. So I think setting up an environment where graduate students are allowed to work on their main body of work and plug into these other streams as they emerge with their own relative strength and then go back to their main work is valuable, because what you want to do is be part of this team producing this research and not have this diversion take over your life because you still have to get your degree. I think that kind of collaborative environment, setting that up is key for graduate students. And that's going back to give people chances to fail spectacularly. And we actually saw a presentation on the exact same way of thinking earlier with IMPART this year. The baseball analogy about how we have to take some sort of like high risk projects on. And I think that having a lot of collaboration is the right model for people to achieve that. Top 3 research questions that clinicians could work on. I think it's hard to find research questions that people all like. My idea of how the physician researcher connection happens means that people's priorities might not line up perfectly, but an opportunity to collaborate under a larger umbrella. Like, so my research isn't all on COVID-19 and policy, it's on population health and policy. And COVID-19 is a massive population health priority. Similarly, aging and technology at APTA has like a strong population health element. So these things tend to intertwine, and you need someone to play sort of quarterback on these issues. But yeah, making those connections happen is key. I'm bouncing around between the chat and the questions, and I'm getting confused. Keith wants to party as usual.
Well, it's 3 o'clock, and as we planned earlier, we have the virtual happy hour.